Hello everybody, welcome to my YouTube channel NurseEd Simplified. Today we will talk about another very important topic for the BSc nursing students as well as GNM and all the NCLEX students, that is liver cirrhosis. Today we will talk about definition, etiology, pathophysiology, clinical manifestation related to liver cirrhosis and its management, including nursing management. Definition: what do you mean by a liver cirrhosis, or another term interchangeably called is scarring of the liver? So it is a chronic degenerative disease characterized by a replacement of a normal liver tissue. See, very concentrate on this word replacement. It is replaced with fibrosed tissues or scarred tissues that disrupts the structure and function of the liver as a consequence of the chronic liver disease. Before that, we must know what are the primary functions. What do we actually do by the liver? Always remember the liver is the highest metabolic organ of our body. There's a lot of metabolism going on inside, which includes carbohydrate, protein, fat metabolism. Detoxification is its second primary function. It basically detoxifies our toxins, drugs, and alcohol. It is a primary storage for glycogen, vitamins, and minerals, as well as it has bile production. It produces bile for digestion of your fat, and it also acts as a filter because it contains immune cells, so it has immunological functions as well. Next, we come to the classification based on the etiology. Why we classify is because the reasons are the contributing factors for the classification. So first is the alcoholic, or what we call the Lennox cirrhosis. It is, as we know, associated with excessive alcohol abuse. First change associated with excessive alcohol intake is nothing but accumulation of fat in the liver. The next is the post-necrotic. That is after the necrosis has already happened. Why we call it post-necrotic is because it is due to the complication of a viral or a toxic or an autoimmune or hepatitis or an idiopathic condition. What do you mean by idiopathic? Idiopathic is anything that does not have a particular or a specific cause to be. Biliary cirrhosis, it is associated with some biliary obstruction and infection, though it is one of the very less common types. Cardiac cirrhosis, it is because of a right-sided heart failure or complete heart failure, what we call. In patient with a constrictive pericarditis and tricuspid insufficiency, we see cardiac cirrhosis. This is also one of the very least, because it is as a complication of a complete heart failure, you get this cirrhosis actually. Risk factors, we as usual we classify them under the age, and it happens in certain ages more specific, that is from around 30s to 50s in among men, in the gender, and in women we see it very less specifically. It will be related to some cardiac reason, and in genetics it has a hereditary component. So if you have a threatening lifestyle, or if you are someone who's alcoholic or using a lot of NSAIDs, you may get a more chance to develop cirrhosis than the rest. Lifestyle, as we know that some lifestyles like alcohol consumption, consuming a lot of NSAIDs, and drugs and toxins have a lot of impact on the cirrhosis. Medical history, a person who has a medical or a family history, they are exposed at a higher risk. Environment, like exposure to certain toxins or risks, can develop this disease. Predisposing factors: malnutrition, effects of excessive alcohol intake, chronic impairment of the bile excretion, the same, like some biliary obstruction, congestive heart failure, drugs and toxins. So now we come to pathophysiology, which is very important to understand. Now, when we talk about pathophysiology, we come first to the etiology. So the etiology says infections, toxins, drugs, alcoholism, biliary obstruction, metabolic disorder, fatty liver may lead to synthesis of fatty acids and increase in the triglycerides, which decreases your lipoproteins. Fat appears in the liver, and that starts to damage the liver cells, and there is inflammation of the liver happening, that is hepatomegaly. This enlarged liver ruptures, and this ruptured liver cells, they form fatty contents or fatty cyst. This develops into fibrosis or scarring. Continuing fibrosis or scarring leads to liver shrinkage. And when your liver shrinks, it alters your liver function. It obstructs the venous channels. Your portal hypertension develops because your portal circulation is impaired because of the blocking of hepatic blood flow. So this is a normal liver which developed into hepatomegaly, and then it starts getting shrinked into a nodular liver. Sign and symptoms are very important, and as I always say, always classify your signs and symptoms system wise, which is always earn you more marks. Number one is the early signs and symptoms. The patient for a couple of months may complain of anorexia, bloating, flatulence, dyspepsia, nausea, vomiting, changes in the bowel habits, that is, episodes of diarrhea with vomiting or diarrhea with constipation, and abdominal pain, lassitude, weight loss, and a palpable liver on examination. Under integumentary, we have jaundice. It results because of decreased ability to conjugate and excrete the bilirubin. Spider angioma, this is one of, I want to highlight this because this comes as your small questions. What is spider angioma? They are small dilated blood vessels with a bright red center point, and it looks like spider like branches. So they occur basically where you will see on the nose of the patient, cheeks, upper trunk, neck, shoulders, on these areas. Next, we come to another uncommon term, that is palmar erythema. That is like a red area that blanches with pressure. So it is located basically, as the name suggests, on the palms. Purpura and petechia, we know it is like a rash. Hematologic, what are the hematological sign and symptoms? Are anemia. They are due to overactivity of the spleen. Thrombocytopenia, why? Because there is increased removal of blood. Leukopenia of the cells, increased like removal of blood cells, so that leads to your coming down. Coagulation disorders, why? Because of the liver's inability to produce prothrombin and other factors essential for blood clotting. And splenomegaly, because when your blood cells or your red blood cells have you start having anemia, your spleen tries to compensate, and therefore it leads to swelling or splenomegaly. Now we come to the endocrine. In men, we see gynecomastia, that is enlarged male breast tissue, loss of axillary and pubic hair, testicular atrophy, and impotence. In women, we see amenorrhea in young age, hyperaldosteronism, and in metabolic, we see that, okay, hyperaldosteronism, just for your information, I want to tell you that it means that your water and sodium retention. Gastro and Next, we go to the next slide. Okay, we go to the cardiovascular. Under cardiovascular, we have fluid retention, peripheral edema, ascites, neurological hepatic encephalopathy. That is because of accumulation of ammonia, increased level of ammonia. Now, what happens to you when your ammonia starts accumulating? Why? Because generally, our what is the function of the liver? It converts ammonia to urea, and it gets excreted. But which the liver, when you are in in liver cirrhosis, the liver cannot do that function. So the ammonia starts accumulating in the bloodstream, and it crosses the blood-brain barrier, affecting the brain function. And this build up ammonia in the brain, it disturbs the normal neurological processes. Now, how? Because it interferes with the normal neuronal function. It disrupts the neurotransmitter balance, affects the energy production in the brain cells, and therefore leads to brain swelling. So, and it can range from mild confusion to coma. Peripheral neuropathy, asterixis. Now, asterixis is also one of the classical signs of uh, liver cirrhosis. When you hear this name asterixis, you must understand that it is related to nothing but, mm, liver cirrhosis, because these are questions which are very important in liver cirrhosis. It is a tremor. It is like it is a movement disorder. It is an inability to maintain a position, which is demonstrated by basically jerking movements of the outstretched hands when bent upward at the wrist. So when he will try to bend it upward at the wrist, he cannot. There will be jerking movements of the hands. Deterioration of the mental and cognitive function. Gastrointestinal is because of conditions which are very uncommon, but they do happen, and that is your feet, fetor hepaticus, and that is nothing but it is like a smell. It is like like a sweet odor that comes from the patient's breath because he has encephalopathy. Esophageal and gastric varices, hematemesis, hemorrhoidal varices, congestive gastritis. That is because of portal hypertension, impaired portal circulation. So this is a small figure showing you exactly what I mean. Esophageal varices, that leads to hematemesis, and then that leads to melena. Then there is splenomegaly because there is altered leukocyte function, dilated abdominal veins, ascites, and so all these happen because of a see, this is a liver flap, or we call asterixis, cause hand tremor. Okay, he will, when he's outstretching his hand, he will not be able to keep it maintained steady. Okay, next we go to the clinical diagnosis. How do you diagnose it? Now we come to mainly history collection and physical examination. This is primary because when you see the asterisk sign, when you see some of the common signs and symptoms like a spider angioma and things like that, you will easily be able to identify this is liver cirrhosis. Other than that, what we do a test called the esophagogastroduodenoscopy, basically just to see the liver, and we have liver biopsy for further investigations. Under lab, we do lots of multiple tests. We do AST, ALT, serum glutamic oxaloacetic transaminase, as I told, ALA, serum glutamate pyruvate transaminase, gamma glutamyl transfer. These are few, like GGT. These are few tests you will hear, very common for patients with liver issues. You will see doctors ordering them. We have ultrasound, and we have upper GI barium swallow meal, and we also have CT scan. CT scan we mean of the liver. Now we focus on the management. Now we always remember we are trying to manage the disease. So we will try to, because the patient will present to you with the complications, we will first try to manage the complication. That's how we come to the management of the disease itself. For example, ascites. If he is our aim is to basically prevent further damage to the liver and restore portal hypertension. So ascites we will try to manage by sodium restriction of 2 gram per day, and in severe cases of 250 to 500 mg per day. Diuretic therapy we will give, and in your diuretic therapy we will include potassium sparing diuretics like spironolactone, loop diuretics like furosemide, and thiazide diuretics like chlorothiazide. And we will also make way for abdominal paracentesis to remove the ascitic fluid. And we have peritoneovenous shunt. Now what do you mean by a PV shunt? We mean it is like a surgical procedure where there is a continuous reinfusion of ascitic fluid into the venous system. Tube, it runs from, as you can see in the picture here, like there is a tube which will basically run from the abdominal cavity through the peritoneum under the subcutaneous tissue into the jugular vein, and from a jugular vein or an inferior vena cava. Okay, next we come to this is how we manage an ascites. Next we come to how do you manage an esophageal varices? For esophageal varices, our goal is to avoid bleeding and hemorrhage. Combination of drug and endoscopic therapy is done. Drugs include what all? We include drugs like octreotide. You will hear that common. Liver cirrhosis, you will hear this term octreotide very much. Vasopressin, nitroglycerin, and beta adrenergic blockers. Octreotide, vasopressin, they are basically to decrease the esophageal varices bleeding. Endoscopic therapies are your sclerotherapy, ligation of the varices, and the shunt therapy. We have also balloon tamponade, which controls the hemorrhage by mechanical compression of the varices with the help of a tube that you will hear SB tube, that is Sengstrom Blackmed tube. So ever you hear a Sengstrom Blackmed tube, it is nothing but liver cirrhosis. And shunting procedure. Now, what is shunting procedure? It is basically used after a major bleeding episode has happened. The patient came to you with a major esophageal varices bleeding. So we use two methods here. We use surgical, non-surgical. Surgical is a more appropriate one that they want to go to. That is a portacaval shunt and a distal splenorenal shunt. They are the surgical shunts that are used. And for non-surgical method, we use something called a TIPS. That is a transjugular intrahepatic portosystemic shunt, where there is a shunt between the systemic and portal venous system and which redirects the portal blood flow. And as we saw here, balloon tamponade with the help of a SB tube and the supportive measures also along. When you're doing all this procedure, we also make sure to support the patient with lots of FFP, packed RBC, and we also try to give vitamin K and H2 receptor antagonist and things like that. Now we want to manage hepatic encephalopathy. So when we want to manage hepatic encephalopathy, we give a dietary protein restriction of 0.5 gram to 1.2 gram per kg per day, and allowing 2 to 3 semi-loose bowel movements with the help of like laxatives. And we also want to give BCAAs. They are like a range of multivitamins which are supported, amino acids which are supported. And under the nutritional therapy, we also give food which is high in calories, but carbohydrate will be 1500 to 2000 calories to prevent hypoglycemia. And also foods that are allowed are like basically toast, cereals, rice, tea, fruit juice, and things like that. Now we come to something called a spontaneous bacterial peritonitis. How do you manage that? To manage that, we have abdominal paracentesis. We do culture sensitivity from the abdominal fluid, and we give the prescribed antibiotics with the help of the culture sensitivity report. We give ampicillin. The most common drug of choice is ampicillin, gentamicin, and third generation drugs are cephalosporin. So this, and the last, of course, the last method we always want to tell our patients that we are looking forward for a liver transplantation because your liver is already scarred. So we are looking for a liver to replace so that it can help in a better condition of living. That's what we always tell the patients. Okay. Now we come to the common nursing diagnosis. We always want to give the best care. So the best priority will come first. Impaired liver function related to whatever the etiological factors are, as evidenced by elevated liver enzymes, jaundice, and impaired coagulation. Fluid volume excess related to portal hypertension and decreased plasma oncotic pressure, as evidenced by ascites, peripheral edema, and weight gain. Also, we want impaired nutrition, less than body requirements related to anorexia, nausea, and impaired nutrient metabolism as evidenced by weight loss, muscle wasting, and abdomen laboratory values. Activity intolerance related to fatigue and high metabolic demands of the body as evidenced by inability of the body to perform the ADL. Ineffective breathing pattern related to ascites and restriction of thoracic expansion because of the ascites, as evidenced by tachypnea, SOB, and low oxygen saturation. Risk for, after writing the the primary diagnosis, we will go for the probable diagnosis. That is a risk, whatever related to risk. Risk for impaired skin integrity related to pruritus, poor nutrition, edema. You can also add risk for infection because of low immunological status and splenomegaly. So these are a few of the nursing diagnoses, very important for liver cirrhosis. Thank you so much. Hope you enjoyed the video. Please do not forget to subscribe, like, share, and support for more knowledge. Let's learn to grow. Thank you so much. Bye-bye.